of your screen. We will pause a few times throughout the session for polling questions and to answer any questions you may have during the session. We encourage you to ask questions or share your comments and experience. And while we may not be able to get to everyone or every question during the session, we will keep track of all of them and send a response to the answers to the group after the session has ended. Please also note that CPE credits are not available for this session, but we hope you still find the information helpful. After the session, we'll put the class material as well as a copy of the slide deck on our Toyon University website for your reference. Our speakers for today's session are Fred Fisher and Ryan Sater. Dave Yoder, the provost of Toyon University, is unable to join us for this session, so Fred Fisher has stepped in to lead the session. Many of you may know Fred, and for those of you that don't, Fred has more than 15 years of experience in the healthcare finance, actually more than 20 years of experience in the healthcare finance and regulatory environment. And though he currently leads Toyon's uncompensated care recognition services practice, Fred spent over 10 years leading wage index and occupational mix engagements throughout the country. Fred is going to be joined by our panelist, Ryan Sater, who is Toyon's wage index service line leader. Ryan has more than 15 years of experience with wage index and occupational mix reporting. Before I hand it over to Fred, we'd like to start with our first polling question of the session. You should be able to see the poll on your screen. Please take a moment to give your best answer. We'll leave the poll open for about 30 seconds, and depending on the size of your screen, you may have to use the scroll bar or extend your screen in order to see all the polling options.
Wow. Hi, everybody. This is Fred Fisher. I hope everyone can see the polling results that we have here. It looks like we do have a good degree of different levels of experience with a lot of you folks with doing 5 or more of these surveys at 32%. 25% of the people here have done 3 to 4 surveys. And 23% have done 1 to 2. The remaining 21% hasn't done a survey yet. So it's very nice to talk to you. I'm glad we have the opportunity to speak with everyone today. I am a substitute teacher and glad to take over while Dave couldn't make it today. And as May said, I actually don't have more than 20 years of experience. I actually have 19, but I rounded up because it just seemed like a nicer number to use on the slide. So thank you. Thank you for being here. It looks like we have a lot of people on this call, which is great because there are a lot of things happening right now, obviously, but one of the, we still have to go about our daily business and pay attention to, what's around the corner. We hope that you and your families are certainly, with everything going on, are doing well, staying safe and healthy during the public health emergency. I think that's the most important thing, to really say to the group here is that, we hope that everyone is certainly doing well. We know that you're busy, trying to wrap your arms around the CARES Act and all the new, policy exemptions and all that. It seems like things are changing every day. So we really appreciate the time you're taking with us today and hope to break up some of the monotony if you are indeed sheltering in place. I have been sheltering in place, and it's an interesting dynamic for us all as we, go about or try to go about our daily lives. So today we're talking about the occupational mix. I think what's interesting about the occupational mix is it's a statistic, right? Like anything we use in the healthcare industry, the occupational mix tells us something about your hospital, right? So it's analogous to if you want to start to think about even things like a payer mix and a dish, right? Well, what is that? That's a statistic that tells us something about your hospital that is used to prioritize funding amongst, the 3,500 or so acute care hospitals that are in the country. So the occupational mix is essentially the same thing, except now we're not the variable isn't your mix of patients, right? The variable is now the mix of your staff. And we'll talk about today why that's important as it relates to, leveling the playing field, as a lot of people say, with the wage index, and talk about, what works and what doesn't. And I think what's really important and what we really wanted to accomplish with you guys today was provide some best practices, because the instructions, like anything else that we deal with, you can interpret them in varying different ways. So we hope that this presentation helps provide some guidance as you guys look forward to, filing the survey this year, and we'll talk about that soon. Also, to recognize the occupational mix is not on your cost report, right? So that's another reason why this is foreign to a lot of folks, and the fact that it's done every 3 years is another reason. So unless you're smitten with the inner mechanics of the wage index, like me and Ryan, this topic can be a bit mind-numbing. But it is, like I said, required to file every 3 years, and we'll do our best to make it as least mind-numbing as possible. But this is essentially why we felt that a refresher session was beneficial for everyone. Because even the most seasoned folks in the industry, we only do this every 3 years, and so it's important to refresh everything. The content in this presentation is intermediate. So we did see a lot of folks on this call have some experience, but there are about, I think, 20% or even greater that have limited experience with the occupational mix. And so again, that's why we hope that we're able to, take you through what this occupational mix is, the best practices, but most importantly, this is a resource document that you'd be able to refer to, as you guys are moving along in preparing your surveys. So our session will cover some of the basics, like I said, from the history of filing the occupational mix. We'll also discuss how the calculation works and the strategies for reporting your data on the survey. When our session is over, our objective is to ensure that you are able to understand why the occupational mix was implemented. There are 5 labor categories that we'll be talking about. The objective is for you to be able to identify those 5 labor categories and determine the types of employees that belong in each category, and recognize what core nursing personnel should be included on the survey, and become, like I said, best familiar with some of the best practices and the nuances with the gray area that we always deal with some of these instructions. So with that, Ryan, would you mind taking us to the next slide, please? So this is, what we'll see here is what is the occupational mix survey. And it's, everything that we do is pretty much relates back to the Social Security Act. And in the Social Security Act, and I'll read this verbatim just because it is a little bit interesting to read some of the words that are interpreted and why we have the occupational mix adjustment. Because in the Social Security Act, it talks about adjusting standardized amounts for area differences in hospital wage levels by a factor reflecting, I think the key word is relative, right? Because again, we're trying to level the playing field, or the occupational mix is trying to level the playing field for wage index. So relative hospital wage level in the geographic area of the hospital compared to the national average. So if you want to make something relative and compare it to a national average, there are certain criteria that CMS wants to take into account, and one of those things is the occupational mix adjustment. And so as if the wage index factor wasn't enough, the occupational mix is a whole other separate calculation in of itself, and we'll talk about that. This was introduced in 2005, and so for those of you that were in the industry in 2005, it was quite a year in terms of the wage index. 2005, not only did CMS bring in the occupational mix adjustment, but back in 2005, CMS moved and redesigned CBSAs all over the country. CMS at that time also implemented the imputed rural floor for any state that didn't have a natural geographic rural floor. And the point I'm trying to make here is, as all this was clarified in 2005 and all this came out, it became burdensome to isolate the individual impacts of everything because of the compounding that was going on between all of the changes that were happening at one time. So just something to think about. And also, since we're going back to 2005, just in case you were curious. The top movie was $1 Million Baby. I think I saw that. That was good. That was with, I think, Clint Eastwood. The top song was Let's Get It Started by the Black Keys. I think we all know that song. And in 2005, YouTube was founded. So we have some fun facts, since we had to rewind the tape 15 years and think about not only our jobs, but what else were we doing in 2005. So CMS used the Social Security Act to basically as the foundation for implementing the Occupational Mix Adjustment. And basically the intent is to try to control the effect of hospital management employment choices, right? And so when we say hospital management employment choices, we're talking about, if you're in a rural area, it's harder to employ a higher degree of RNs as it is to LPNs, nursing aides, and medical assistants. Those are the categories, and we'll talk in further detail about that. Whereas if you are in other more city areas or other areas with higher labor markets and recruitment efforts are easier, or people want to, move to that location or naturally live in these locations, you can have a management decision to hire a higher degree of RNs, RNs as compared to LPNs, nursing aides, and medical assistants. So CMS was trying to control for the effect of all this as it affects, the wage index. And so that was the basis of, the occupational mix coming out in 2005.
Yeah, and I'll just make mention there, Fred, and hi, folks. I'll be sort of interjecting here with some color commentary. But one sort of interesting point about all this, in terms of at least CMS trying to control management's effects, I know there's a number of folks on the phone from California, for instance, and California as a particular state, their hospitals are at a disadvantage due to, required RN to patient ratios. They're required to have a certain number of RNs on the floor relative to the number of patients. And so you could kind of make the argument that this is a mandated requirement for states' hospitals, and not really management's decision to hire a certain degree of RNs, right? And as we'll see as we kind of get down, we'll talk about the impact and how this impacts the average hourly wage and the wage index. We'll see how California in particular is impacted negatively as a result. And I'm not acutely aware of other states, but I'm sure there are other states that have similar, what I would call, unfairness when it comes to it. And this has been addressed throughout kind of the rulemaking process each year. But as far as I've seen, nothing's been done. I haven't seen an appeal or anything that sort of has changed this or addressed this. But I just sort of wanted to mention it here as kind of an ongoing challenge. But again, CMS has all kinds of ongoing challenges, so they sort of have been sticking to what they think is appropriate. And I could see folks arguing one way or the other. So it's an interesting adjustment, and we'll get into the calculations of it. Fred will go over all that, and we'll see why there is the impact that it is.
Thank you, Ryan. That's a really good point. Appreciate that. And so really, when we talk about why was this implemented, I'll be relatively quick on this, but it was truly a result of effective advocacy from rural hospital groups or rural groups that represent rural areas. And so, like I said, they do struggle with shortages of available staff, lower reimbursement, have many other challenges. Recruitment is always a challenge, and payer mix and those types of things. So rural hospitals simply cannot afford to have higher mixes of RNs and LPNs and aides. And so the argument was their wage index factor, which has a direct relationship to how much they are paid, was exacerbated by their lower mix of labor. So CMS did react to the advocacy of the rural hospitals and built the Occupational Mix Adjustment. And we'll talk about, when the Occupational Mix Adjustment did the intent marry the expectation, or did the expectation marry the outcome? The expectation was rural hospitals would see, a bump up in terms of revenue. I mean, ultimately, we're talking about an occupational mix adjustment, but at the end of the day, it's revenue. And the other expectation is that urban hospitals would see, the offsetting decrease, right? This is a budget neutral system. And so there would be a push and a pull, or the expectation was there would be a push and a pull between the rural hospitals and the urban hospitals. Go ahead, Ryan, please. So that was a nice theory. but what actually happens. And so there's a lot to go into this, but it's, you know, the expectation, the outcome did not match the expectation. The big reason for this, and it has to do with how the wage index is calculated, but a lot of rural hospitals are smaller, right? And so when you think about when a hospital, and this goes for, you know, anybody on the phone, you know, when you think about the size of your hospital and the CBSA, you know, the wage index is a composite that's really dependent on the large hospitals, right? So if you have a large hospital with hundreds of $1 million in salaries in your CBSA and your hospital has $2 million in salary, anything your hospital does is not going to have a dramatic impact. It's very de minimis, right? And so that's essentially a part of what happened, because rural hospitals, by their nature, have a much lower weight based on their salaries than their urban counterparts. So they weren't able to influence the wage index and the occupational mix as much as was anticipated. And then secondly, and we'll talk about this too, the occupational mix only is adjusted to the nursing proportion of a hospital's salaries. And so, you know, we'll discuss what this means, but, you know, about half of salaries used for the wage index are occupational mix adjustment, meaning half the other salaries fall into this all other category, which is where you and I and a lot of the folks on the phone fall, you know, overhead, finance, you know, accounting, all those types of things fall in the all other category. So, you know, to the degree that you have a positive occupational mix factor, if you don't have that many nursing personnel as compared to maybe your all other personnel, the effect of that factor is not going to have the outcome that likely was anticipated. In case of rural hospitals, even when their occupational mix is positive, so they might still see a negative impact due to the CBSA that they're in. What's interesting when we talk about rural too, I just want to make a note of this, is, you know, throughout the country, CBSAs are really nothing more than aligned counties that are connected, right? But the rural area is not. You know, if we look at California, if we look at other states, the rural area is a pocket of rural wherever that pocket exists within the state. And so I just think that's important to talk about as we, you know, think about, well, there could be some other hospitals that might be considered rural that are happen to be in an urban CBSA. And then with, you know, the rural hospitals that sit throughout the state, those hospitals all, you know, they don't share a tremendous amount in common other than being rural if they're all in different locations. So just something to think about from that perspective as well. So if we turn to the next slide, please, Ryan. So this is the actual implementation of the occupational mix adjustment. In 2005 and 2006, CMS started to phase in the occupational mix adjustment, but they only did it at weighted at 10%, meaning whatever your factor was, they were just going to weight that down to 10%. Kind of what CMS always does when they phase in new things is they phase it in, right? They have a 10%, 90%, and maybe they're going to look to do 50-50, and then 90-10, whatever their phase-in plan was. But that's not essentially what happened, because after 2 years, there were comments from the provider community that the occupational mix adjustment was not having the intended consequences that were suggested by CMS. And CMS approached Congress actually about repealing the occupational mix adjustment. And so, however, you know, after such case, though, there was a case, Bellevue versus, I think it's Levitt, excuse me if I misenunciate that. The court essentially ordered CMS to apply the full occupational mix immediately. So by September 2006, this was in full effect. And so in the proposed and final rules for 2007, CMS stated they would be, you know, fully implementing the occupational mix. So a little bit of history. I think it's important because it kind of takes us to where we're at today. You know, the intent, you know, kind of following what the plan for this was, married against the intent. You know, the outcome still isn't what folks expected, yet here we are still doing the survey. So it's an interesting, you know, kind of perspective on all this. CMS issued a joint scheduling memorandum instructing MACs to collect occupational mix back in 2007 using 2 3-month surveys and applied at 100%. So they've come a long way, right? They've done a lot to respond not only to advocacy, but also to other governmental entities in applying this adjustment. And so with that, that's why we're talking to you guys today. Ryan, would you mind? Next slide, please.
Yeah, and let's face it, Fred. I would think CMS probably just didn't want to handle the nuances of that calculation. You know, the Occ Mix itself is already kind of a pain in terms of how it impacts the wage index, and then you're going to do 10% and something. I mean, that seems crazy to me, right?
Yeah, I know. It was a complicated year, or a couple of years.
I bet with the computer report, like you said, yeah.
Yeah. And so typically, so here we are, right? Like we say, it's a triennial survey done every 3 years, and here we are. The next survey is upon us. It was scheduled to be due July 1st, but due to the healthcare crisis and COVID-19, that's been moved back to August 3rd this year. I will say, in working in the uncompensated care world and cost report world, and Ryan, maybe later you could speak to this. This deadline, it might be fluid too. I think that a lot of the dates that are out there, we're trying to, push them back, but understand that, the world is changing fast. And so I think it's a smart idea for folks to just stay on top of that deadline to make sure that that sticks, as the next couple weeks and months go by.
Yeah, no, it's a good point, Fred. And I'll just mention too, in the actual, because that extension, and it's good to make point of this too, because folks maybe haven't seen it, because it was sort of just buried in all this other legislation that's been out there, right? And so folks maybe weren't even aware that they extended it. But anyways, in the actual, I guess, memo, if you will, or release that CMS put out there for this, they do say, August 3rd is the date that they've extended it to. But if you're having issues, please contact your MAC and just let them know. And they're going to basically sort of work with you from there. So it's like Fred said, it's kind of I think it's somewhat of a fluid date, but do the best you can to get it filed by then. But obviously, if you're struggling, I mean, cost reports for our 1231 clients are due now at the end of July. So what, CMS gave us 2 days to do the occupational mix survey after that, right? Stay in touch with your MACs if you're running into issues or anything. And I think they'll be flexible. Seems to be a common word in CMS's vocabulary that they don't normally have in their vocabulary is flexibility. So.
Yeah, and thanks, Ryan. And what we've learned with a lot of this too is folks if you're working from home, and if you have to tap into large databases like a payroll system, or we understand that it's can be problematic or troublesome to figure out how to get some of this data if you're working remotely. A lot of that type of information helps articulate why you might need a further extension. So just if that helps anybody on this call. Okay, cool. So so I just jumping to the year that's being collected, right? It's obvious. It's much simpler if you are a calendar fiscal year end, right? Because then the information you have at your fingertips essentially fits with what CMS is asking for. It is a little bit more work, I'll call it, for anyone that is not a calendar year, December 31 fiscal year end. These folks essentially take and combine data from 2 fiscal periods to ensure you've captured all the data for calendar year 2019. This simply just means that you will likely need to run separate reports covering the appropriate periods for calendar year 2019, rather than relying on your current fiscal year end data that you may have compiled for your cost report. And then barring any further postponement, the results from the survey will be audited in the fall, along with the annual wage index data revisions that are submitted each August or early September every year. The final occupational mix factors will then be included in the proposed and final rules for 2021, which will apply to the upcoming federal fiscal year 2022. And so that is why the results of the survey will be applied to the wage index for federal fiscal years 2022, 23, and 24. And I'm going to pause here and just let folks know that I think it was late last week we started to see the psych or the rehab. A couple of the proposed rules came out last week. I would anticipate that it looks like CMS is on schedule in releasing their rules, and that the 2021 proposed rule, if I had to guess, it would be out next week. And that's my guess. Please don't hold me to it, but based on what we've seen in the past. Also, we find it, interesting, although I don't know where CMS gets their estimates. They estimate it will take an average of 480 hours to prepare the occupational mix survey. So if that is 1 FTE, that would be essentially 25% of your annual time. I don't think that is a realistic number. I do think it shows, though, if you were to perhaps interview every nurse in your hospital or, go through and essentially a very detailed approach, perhaps it would take 480 hours. I don't think many people are doing it that way, especially in an era where we have a lot better systems at our fingertips to analyze data and work with folks. But it's interesting that the 480 hours is certainly an interesting estimate by CMS. The other thing that's interesting about all this is back to the deadline. Yeah, the deadline is now August 3rd, but it's also interesting, hospitals can revise this thing right away during the audit in the fall. And so we're not suggesting that hospitals just go ahead and file anything by the 3rd, but just know that you do have an opportunity right away, essentially, to correct anything that may need corrections. You also have an opportunity every year, along with your wage index, to revise your occupational mix survey should you uncover any findings throughout that 3-year cycle. Go ahead, Ryan. Okay, so when it comes to compiling the survey, it's a little tricky to get the data that, like I said, to match calendar year 19, as every organization does indeed have different pay periods. So CMS has put in some stipulations that you should include all pay periods that you have reported in your 2019 GL. The beginning date of the initial pay period cannot be prior to December 17th, 2018, and the ending date cannot be later than December 31st, 2019.
Yeah, and let me just stop you there for a second, Fred, because that may seem sort of odd to folks, but that is in the instructions specifically stated, and your max will ask. They will ask you specifically what pay periods you used in terms of the payroll reports you run. So bear that in mind. I mean, you should have 24 or 26 pay periods depending on your cycle, but just make sure the date range that your IT folks are running, whatever reports you're running, are within that range. That's the beginning date of the pay period that you're starting with, pay period 1, which is likely ending, 1/2 or 1, sometime in January. Doesn't start prior to 12/17/2018, and then the last one ends, at 12/31/19. So at the end of the day, you should have, like I said, your 24 or 26 pay periods. But just bear in mind, because if you don't pay attention to this on the front end, and then all of a sudden you give the MAC an honest answer when they ask you the question, you go, oh shoot, I meant to. It does include this. They'll have you redo it. They'll say, nope, give me new pay periods, which seems crazy enough to me. If it probably doesn't really make that much of a difference, but they'll ask. So it's a good point. We wanted to make sure we mention it here.
Thanks, Ryan. That is a good point. And if I haven't clarified this already, too, I mean, we're talking about IPBS hospitals that do include, if anyone's on the phone from Maryland that has the 1115 waiver, as all these hospitals are impacted by the occupational mix adjustment. Critical access hospitals are not required if anyone is on the phone representing a critical access hospital. In addition, if you are a no or low utilization provider, you would not have to complete the survey, but there are not too many folks that would fall in those categories.
You know what, Fred? I don't want to digress us here, but I didn't realize that Maryland had to file these things. I guess I understand why, but it just seems kind of, I don't know if you knew why. It just, they're They don't have wage, they're a waiver state. I don't know. Anyways, I guess
Yeah,
they need to be
no,
included in the national numbers. I didn't realize that, to be quite honest. So.
absolutely. Yeah, and without being completely factual, I think it has something to do with updating the cost every year, but appreciate that.
Yeah, no, I digress. I'm sorry.
We do digress. It's okay. So all the information is published by CMS in their occupational mix survey instructions. So if you don't have all this information, it's right on the CMS website, and we also have it linked here for folks to easily go and access the CMS instructions, so you could see all this kind of verbatim. So now let's take another cool poll break, please, and see what kind of results we get.
Great, thank you, Fred. It's time for our second poll of the session. You should be able to see it on your screen right now. Take a moment to give your best answer. We're going to leave it up for about 30 seconds. Also at this time, please feel free to type any questions you may have so far into the Q&A box, which again can be accessed on the Zoom ribbon at the bottom of your screen.
I'll just read the question here. Historically, has the occupational mix adjustment generally helped or hurt your hospital's average hourly wage? Some of you may or may not know, and we'll get to that, but we'll let it go for a few more seconds here. And we'll give it 5 more seconds. All right, time's up.
All right, thank you, Ryan and May. So let's see, out of the, looks like there's about 80 or so people on the call. 22 people responded, it's helped their average hourly rates. 24 people responded that it's hurt their average hourly rate, and 29% don't know. So greatly appreciate your responses. I think that a lot of this too is, typically, well, we'll see this in a second. Typically, you can kind of estimate, well, should my occupational mix increase or decrease my wage index from what I know, about my hospital and about the way that we staff our folks. But sometimes, even what you think you might know is counter to how the results pop out. And so with that, let's take a look at what we've done on the next couple of slides, just to kind of illustrate the impact and who's impacted. This list shows the top 10 across the entire country, the top 10 hospitals that are most negatively affected by the occupational mix. And if you look at this, right, I think seven of these CBSAs are located in California. Little caveat, 3 of those, though, however, received the California rural floor. So we'll talk about cursory review type of things in a minute. And then I think we have 1 East Coast, right, West Palm Beach. And if I was in West Palm Beach, I would go, why am I on this list? Where's the rest of Florida? Where are my other like markets for Florida, right? And so there are certain things that you can initially glean. All this is public, just so everyone knows. This is part of CMS's public use database. So it's interesting, right? And seeing that 258 in Sacramento, I mean, that's a large adjustment. I think that general consensus, if anybody wanted to ever convert these numbers to like a wage index, I believe, Ryan, step in here, I believe every 50-cent impact decreases or increases your wage index by, I think, a value of 0.3. Is that still accurate, Ryan?
Sounds fair.
Okay, well, we'll use it. I think last time I checked. But that's a lot, and so in Sacramento and a lot of these areas, I mean, we're talking millions of dollars here.
Oh, yeah, well, exactly, Fred. And we put in perspective that way. I mean, obviously, depending on your Medicare concentration, but I mean, a $2.58 hit to the Sacramento hospitals is, you're talking millions and millions of dollars,
Absolutely, and this is
over a 3-year period.
3-year period, absolutely. You start to consider this, a lot of people, we talk about wage index as an inpatient program, but there is certainly an outpatient component. And then there's always managed care components too, right? When folks contract with Medicare managed care plans, if the wage index, which likely is a component, I mean, you have to think about that too. So thank you. So let's take a look at the top 10 CBSAs. So I don't see too many rural areas. I see small markets, you know. And this is, again, I mean, this is a complicated system. We have, unfortunately, and you know, this is not a knock on any auditors, but we know that there's varying interpretations of the rules with how some folks are audited. Some folks experience a more intense audit as compared to other folks. But when we look at the most recent data, I mean, we do see, you know, these folks are the ones that are quote unquote winning, you know, from the occupational mix adjustment and experiencing those that positive revenue coming in. And so it just kind of puts things in perspective. We talked about the intent, right? Did the intent match the outcome of the occupational mix? And when I look at this schedule, I say, no, probably not, you know? And therein lies, you know, maybe the reason that, you know, CMS collects this every 3 years. Maybe it should be every year, I don't know. But these numbers will move around, you know. We're not privy to the MAX audit program, so we don't know if they rank CBSAs and hospitals like this, but they should. But we've seen occupational mix factors take dramatic turns from one 3-year period to the next. And it could be because in a prior survey, perhaps there's an error, and all it takes is one error at one hospital, and that happens, you know. So, okay, so there's the top 10 there. See if I have any other notes on here. I don't know if Ryan, you did any thoughts on
we'll get into this a little bit, but I just to kind of put this into context, how these numbers sort of, these impacts are calculated. You know, the key driver, as again, we'll talk about this, is the lower mix of RNs relative to the other nursing staff, you know, the LPNs, aides, et cetera. So just to give you in perspective, if the average level of RNs to other nursing staff is like it's 71% across the country. I think I had looked, to put this in context, Boise City, Idaho, which I think only has like 2 hospitals, but that's neither here nor there. Their average is 54%. You know, so that's basically the driver of why they're seeing an increase here. And again, Fred, in the next couple slides here, is going to talk about, you know, how that's derived. But it's just sort of interesting to note that that's the key driver here, 54%. Whereas if we look back at, if we look back at these California hospitals, I'm sure Sacramento is probably closer to 80% or something, you know.
You know, and Ryan, what's interesting too, as we talk about maybe a place like Boise as it relates to Sacramento, like you said, 2 hospitals versus 40 hospitals becomes much easier to manage, right? So if folks are on this phone, if they're a part of larger CBSAs, you know, sometimes, you know, you'll find yourselves in more of a concentrated effort on working together to make sure that, you know, everybody's doing their part. Whereas if you're in a CBSA with maybe 2 to 5, 6 hospitals, you know each other, it's, you know, smaller market, things tend to be a little bit easier to manage in those circumstances. So just a thought there. Okay, cool. So what if you decide, nope, not filing this thing, it's not worth my time, I got too much other stuff to do. Right now, if that happens, there's really no penalty. What CMS does, although if you read the rule, CMS always discusses their right to reserve a penalty for hospitals, but they haven't implemented it yet over the last 15 years. But what CMS does is if you do not fill out a survey is, a lot of people call it, you get the average CBSA, and I guess that's the right word. But what they'll actually do is they'll take every hospital's RN salaries in hours, their LPN salaries in hours, et cetera, all categories for your CBSA, and they run it through the calculation, and that's how they get the factor. So it's different than, you know, hitting, you know, equals average and just taking the average of all the occupational mix factors in the CBSA. So just something to think about. You know, I think when we look at the current 2020 listing, out of the 3,500 hospitals or so, there was 167 that did not file a survey, and I think that you know, that threshold is probably okay with CMS. But I do think that if, you know, I do think CMS, and I do believe they keep their eyeball on it to make sure that it's a reasonable number every year. So just something to think about when it comes there. Obviously, we would never advocate for anyone not to file a survey, although that could be a strategy that people take. But again, CMS watches this pretty closely. And the MAX, and Ryan, you could probably speak to this too, the MAX do follow up and kind of hound you to make sure they get that survey out of you too.
Yeah, they do. They do.
All right, so what we're going to do next is we're going to go through, how does the calculation work? And we're going to do that in two ways. The first thing we're going to do is kind of like a narrative, right? These next two slides are just kind of a narrative for those folks that like to kind of read things. And then we have about 5 slides that walk through CMS's calculation to just show you, how all the factors work. And then after that, I'm going to wrap it up, and Ryan's going to give you some really important information on, okay, so now that we know all this stuff, what do you do to report it? So in respect to that too, I'm going to move a little bit faster than I have been moving, because I do want Ryan to have a considerable amount of time here at the end. And so the first thing we'll notice is step 1 is driven by hours, right? So when folks are compiling RNs, LPNs, nursing aides, medical assistants, what really matters initially, right, although you're compiling salaries and hours, are the hours. The higher percentage of the hours essentially determines your weight, right? And as we talk here, right, and as we know, RNs, it's really an exercise of what is the weight of the RNs as related to the weight of all other nursing care folks, meaning medical assistants, LPNs, surgical technologists, and nursing aides. The higher percentage of any of those provides a higher weight. So if you have higher RNs as compared to the national average, you're going to have a lower occupational mix factor. So how do they do that, though? They take the sum of all the weighted average hourly rates by nursing category to develop a provider-specific average hourly rate. So they'll take all those categories, determine your hospital's average hourly rate, or determine your hospital's percentage, I should say, of nursing, and they multiply those percentages against the national average hourly rate for each category, and that's how CMS gets your weighted nursing average hourly rate. And it's really a matter of determining, are you above or below 1? Should you be, where do you rank against the national? That's kind of CMS's science to do that. Next slide, please, Ryan. And so the next step of the occupational mix calculation, though, is after you get through determining the proportion of nurses at your hospital and the weighted proportion of nurses as they relate to the national average, this is where salaries come in. And the nursing salaries are then compared against all other salaries. And so this is where, again, if you have an occupational mix factor that's above 1, you want ideally this proportion of nursing salaries to be higher, right? Because it will give you a nice weight of your occupational mix adjustment as it's applied to your average hourly rate. And I do realize I just rhymed. And so, yeah, so they take the all other salaries as compared to nursing salaries and determine that threshold. And that's how much CMS determines is weighted against the hospital's average hourly rate. So what I'll do, this is a lot, we can kind of get into, we'll get into the CMS calculation so I can illustrate this for you. And again, this is not a Toyon template. I would have chosen different colors, but that's all personal preference. But so here we have the CMS calculator from 2019. You can see how they're collecting it, right? We have provider hours by Occ Mix category. You can see RNs, LPNs, and surgical technologists, nursing aides, and medical assistants. And I'm colorblind. I believe those are shaded in pink or purple. One of the two.
Pink's pretty all right.
Was I close? Okay, thank you. And so you can see in step 1 what CMS is going to do, and we're going to walk you through this with live data. But you can see in step 1 that provider percentage by subcategory. That's just a result of, if you look at the occupational mix hours divided by the hospital's total nursing hours, right? So that's what that represents. It should always sum to 100%. You'll see step 2, Ryan, you can go ahead now because this helps. Yeah, thank you, man. So here you go with some live data, right? And here you go, you could see the subcategories do indeed total to 100% using the occupational mix hours that were filed by this hospital. What's interesting here is you can see that 83% of the hospital's nursing personnel are registered nurses. So what's going to happen is CMS is going to take that 83% and multiply it against the national average hourly rate to get that weighted average hourly rate we just talked about, right? So there's 34.57. And CMS does this across all categories And so you could see that at the end, right, when you total everything together, you get an average, a weighted nursing average hourly rate of $37.78. This average hourly rate is now compared against the national. So CMS does this exercise for everybody and determines, well, what's the national nursing average hourly rate? Well, it's $35. You pay more, right, for your nursing mix than the rest of the country, and therefore you divide one into the other, and you get the occupational mix adjustment of 0.92. Okay. So hopefully that makes some level of sense to folks on the phone, but we're not done yet, right? Because now that we know your factor, the question is, what do we apply this a factor against? And the answer is you only apply it against the percentage of salaries at your hospital related to nursing. So here's where the salaries come into play. In this case, the 0.92 occupational mix factor is going to be applied against 53% of the hospital salaries. And when I say 53% of the hospital salaries, now I'm talking about the salaries that are reported on Worksheet S3 Part 2 that CMS uses for your average hourly rates. This is how they accomplish adjusting those salaries. And so those salaries are going to be adjusted down by about 8%, right? And so when you adjust down a hospital salaries and you leave the hours as they are filed, you are left with a lower average hourly rate than what you had initially filed. So this hospital that we're using here, which is hypothetical, it's an unadjusted average hourly rate before occupational mix was $34.42. We just did everything, all these steps, applied a 0.92 factor against 53% of the hospital salaries. And now the provider's adjusted average hourly rate is $33.07. That is $1.34 that comes off the hospital's average hourly rate. So what I'll say before I hand it over to Ryan, because Ryan's going to kind of go through and articulate a lot of this, is so as you look at this, like for your hospitals, right, you start to ask yourself some questions. So if I was this hospital, I would say, shoot, did I get all my all other? Because is there a way for me to change that 53%, right? Assuming that I'm comfortable with my survey, am I comfortable with the allocation of nurses to all other? And then maybe, oh, I didn't get the contract labor. Oh, I forgot the home office, right? There's a lot of all other categories Ryan's going to talk about. But when you accumulate and you get those categories, you are able to offset the impact of the occupational mix adjustment if it's a negative, and vice versa with the other way too. Go ahead, advance the slide, please, Ryan.
And I'll just say there, thanks, Fred, and I will get into this, but I think to sort of emphasize what Fred's saying, it's important to understand this, and in your sort of summarizing of the data as you compile it, put it in this form. You know, use the form, use a template, use something to see it. Because if I'm like Fred said, if I'm in this hospital and I'm seeing 82% of RNs, I'm going to go, man, that's kind of high. Knowing that the relative, at least, you know, knowing that the average across the country is roughly 72% or so, does that make sense? You know, does 12% of national, you know, nurse aides, does that make sense? And you may or may not know, but it's just something to think about, you know, compared to prior year. And we'll go through these kind of best practices and whatnot, but it's important to understand the calculation because then you know kind of what levels you can pull, you know, within reason, obviously, and what makes sense. I think we got to take a break for a poll here, and then we'll kind of dive into the details. Go ahead, May.
Thanks, Ryan. Okay, you guys should be able to see your poll up here in a minute, and we'll leave it up for about 30 seconds again. Take a moment to give your best answer. There's 3 possible answers, so I don't think you need to scroll or anything to see them all. You should be fine. Again, you guys, this is a good time to put some questions you may have into the Q&A box, which can be accessed in the Zoom ribbon at the bottom of your screen, and Ryan can get to those as well.
We'll give a few more seconds to get your responses here, and I do see a question. We finally got a question in there. Fred, you were doing pretty good there. We didn't get a single question there for the first 50 minutes or so. So let's kind of give it a few more seconds here. We'll check the results, and then I'll address the question that came in. All right. So sharing the poll results here. Let's just take a quick peek. Do you annually meet with your HR and nursing admin teams to review job descriptions? And we got 4 people that say yes, annually. And that's great. 61% say no, and then others say during an occupational mix year. And we'll go through why this is sort of important. I suppose if you compound the amount of time you spend going through job descriptions and whatnot, maybe somehow you get to 480 hours over the course of the process, but I doubt it. But it's good to do this, and again, we'll go into the detail as to why this is important. So let me stop sharing here. Advance to the next slide. But before we kind of dive in, I do have a couple questions, and I'm going to answer these live. Again, if you have questions, please don't hesitate to type them in. If we can't answer them, or if we get distracted or something, or we get too many, we'll get back to you directly. But I'll take a couple of these since we've only got a couple. One person asked, do we have Santa Cruz, Watsonville, California impact? And we do. I think, I don't know that Fred mentioned it, but we can provide you, Eleanor, we can send you something separately, certainly to kind of show you the impacts there. That's not a problem, because we can put all that together. I can assure you, based on where you are, that it's not going to be pretty in terms of the impact in Santa Cruz, Watsonville. I don't know off the top of my head, but I'm going to guess it's negative. If it's not, I'm going to be very surprised. And we'll give you, I'll get you a dollar amount too. Like Fred had mentioned in the actual, when we saw that slide, it's all public data. We have models and stuff where we can calculate this stuff pretty easily. So I'll be happy to provide that to you, Eleanor. One other question, is the percentage applied to just the nursing salaries or total salaries?
Nursing, right?
Yeah, right. So in terms of the percentage that Fred, and let's go back to that slide real fast. Oops, sorry. In terms of the percentage, in this particular calculation, you can't really see the calculation, but coming off the S3 Part 2 data that's compiled, your wage index data, 192 million is the salaries that were compiled, based on, your salaries, excluded areas, plus contract, labor, wage related costs, et cetera, 192. So they basically, what CMS does is they take that 192 and multiply this factor, right, the 0.9273 by 53%. So in this particular case, like Fred had mentioned, you've got about an 8% reduction multiplied by a factor, or multiplied by a factor of 53%. So they take the 192, and they basically say, okay, 53% is going to be reduced by the 8% or so, and that's 95 million, plus 100% of the all other, which is basically just the 192 at 100% of 46%, 89 million, to get to 185. So basically the 192 goes down to 185. The hours that come off your S3 Part 2, they don't touch those. That stays the same. So you're just seeing roughly a $7 million reduction in salaries straight off your S3 Part 2. So it is, to directly answer the question, the percentages applied just to the nursing salaries. So like Fred mentioned, that's where the salaries come into play, is that sort of secondary calculation that they do. I hope that makes sense. And if you have further questions on that, Ed, just please don't hesitate to shoot us an email and let us know. We got one more question. Let me answer this one here. Non-face-to-face. So the question is non-face-to-face with patients employed RNs, include in the nursing category. And that's a great question, Tim. Thank you for that. I'm going to address that pretty much right now. So let's sort of move on, and I'll speak directly to that, because I think, as Fred has sort of been talking about, we know why we have to do this, right? Excuse me. We've discussed how the calculation works. Now we're kind of getting to the meat of it. And just so everybody knows, I think we set this thing up until 10:30, so it's an hour and a half. I'm going to try to go through this. I don't want to. This is important because this is the meat of it. So I'm going to go through this as thoroughly as I can, given the time, how much time we got left. Obviously, don't hesitate to ask questions. We'll answer them as we get to sort of the end of the slide deck here. We've got about 10 or 15 more slides to go through. Please don't hesitate. If I miss something, or if you have questions, or if you're not sure, ask. Or certainly we'll take questions offline too. Hopefully you've got our emails and whatnot. So this is the meat of it. Let's get into it and talk about what we're actually reporting, and kind of, I want to talk about kind of the best practices in terms of how we approach it when we sort of do these things. Because I'm not going to pull any punches here. I don't mind giving away. There's no secret sauce or anything to give away. I just want to sort of give you some ideas on the kind of what the best practices are. So, all right. So let's talk about what data is used, right? So the wages and hours that we're collecting are for salaried and contracted. So I just want to emphasize contracted personnel, just to make sure folks realize that that includes A&G contract labor, housekeeping contract labor, dietary, registry, all that stuff gets included. And they're collected for these 5 categories, which Fred has talked about, right? The top 4 here are nursing categories: RNs, LPNs, and surge techs, surgical technologists. I don't know why they combine those in one, but they do. Nursing aides, orderlies, and attendants, medical assistants, and then everybody else. So you have a catch-all for basically everybody else. And we're going to discuss these. We're going to discuss the 4 nursing categories in more detail here in the upcoming slides, and then we'll kind of speak to the all other, and talk about what sort of gets included in there. Certainly want to mention wage-related costs. Fringe benefits are not included as part of the occupational mix survey, so that's nice, right? We don't have to worry about wage-related costs or the pension calculation, self-funded health insurance, or any of that stuff. So there's still a factor, obviously, in your hospital's average hourly wage, but you don't gather it for purposes of the survey. And then another key point: only patient care personnel from the core nursing cost centers are used. So as we'll see in the next slide here, we're only going to report personnel for the nursing that reside in what CMS has defined as core nursing cost centers. So let's take a look at those. All right, so these are the core nursing cost centers straight off the instructions. Note that these have not changed in recent surveys. Nursing personnel are, we're going to divide those 4 categories that we spoke to based on these. So in other words, if you've got nurses that fall, to give you an example, let's just say you got an LPN that's working in radiology, right? That would be on line 54 of worksheet A. They wouldn't be reported in any of the 4 nursing categories, right? So they're going to be considered the all other. So one of the first things you want to do, obviously, when you get your payroll data, you've got your job codes, you've got your descriptions, and you're sorting through it, put in those worksheet A line mappings. Put in the mappings, sort by the mappings. Anything that falls outside of these categories, boom, all other. All other are excluded, which we'll talk about. But keep that in mind. That's sort of the first thing you want to do, because that's going to narrow your population of what you need to analyze, what you need to be sort of go back to the polling question. What do I need to be talking to my HR, nursing, admin staff, or payroll about? These are the job descriptions. And of course, as you're sort of doing that exercise, use materiality, right? Like, certainly focus in on the ones that have the greater proportion of dollars relative to your payroll, right? Obviously, you're going to have, more RNs and LPNs, but if you see, depending on the size of your hospital, a large concentration of a certain job description, look into it, obviously. And again, so I just want to emphasize that, these are the core nursing categories. So definitely pay attention to these. That's sort of step 1 in terms of how we want to sort and sort of slice and dice the data as we get into it. Okay, so let's go over, and I'm going to sort of read some of these slides verbatim, but I want to sort of emphasize some of the sort of tips that we use when we sort of look at this. Let's take a look. We're going to take a look at each of the categories for nursing personnel, starting with the first one, RNs, right? All right, so RNs, pretty straightforward. These are pretty easily identified in your payroll records. License and registration is required. What does an RN do? An RN assesses patient health records and needs, develops and implements nursing care plans, and maintains medical records, et cetera, right? These are your boots on the ground. These are your floor nurses. These are the folks that are really doing the patient care, right? And they're certified. So it's important to note that these are your certified folks. Here's some examples: RN1, RN2, pretty simple. Nurse clinician, nurse manager. Note the asterisk. We'll talk about that. Nurse supervisor, charge nurse, etc. So what do we exclude here? Okay, when I'm looking at sort of my population of RNs, what am I excluding? All right, well, my advanced practice nurses, so, you know, your CRNAs, your clinical nurse specialists, certified nurse midwives, anybody that bills nurse practitioners, anybody that bills Medicare Part B separately and are not paid under the IPPS, those need to be excluded. And when I mean excluded, I just mean removed from the survey. So the best way to sort of think of this is, if you exclude them for purposes of S3 Part 2, right? So if you have salaried, you know, call it a nurse practitioner, that you report on the specific lines, it'd be line 5 or line 6 of S3 Part 2, if you're reporting those and identifying those as Part B, then those should be removed from the survey. So take them out entirely. Excuse me. One also point before I sort of mention this little tip is I tend to sort of think about, when I think of RNs, there's kind of a nursing floor hierarchy, right? So you've got, if I'm thinking of a patient, of a nursing floor, just a patient level care, you know, med surg, whatever you want to call it, you've got floor nurses, right? You've got your floor nurses that are seeing patients and doing, you know, doing their job and on the front lines. You know, those are the folks that we can't say enough about it right now, right? You know, these are our heroes that are on the front lines doing what they need to do. Those are RNs, right? Those are RNs, easily categorized. And then you've got to level up from that, right? You've got these clinical coordinators, or, you know, that are maybe helping oversee the patient care. They may not be directly involved, but because they're one step above, and this, I think, addresses one of the questions that I think came in from you, Tim, the folks that are one level above, that are supervising these floor nurses, those are still, according to the instructions and the way we see these things, those are still RNs as well, right? Assuming they're an RN, which they should be if they're overseeing RNs seeing patients. Those are still RNs. Where you start to see, and this gets into kind of our little tip here, where you start to see sort of the next level up, so I guess 2 or 3, the third level removed or second level removed from the floor nurse, these managers, you've got a nurse manager who's maybe not on the front lines, not directly seeing patients. You know, they sit behind a desk somewhere or whatnot. Frankly, I'm not entirely sure. I'm not a clinician. But those folks that don't oversee, you know, patient care directly, they're not face-to-face nurses, those we would consider as all other. Those are considered administrative RNs that are not directly involved with or managing other RNs who provide direct patient care. We would recognize those as all other, unless excluded, like those folks that we mentioned. So I think it's important to note that, right? So that's, like I said, the second or so level removed from the floor nurse. And then obviously your VP of nursing or your chief medical officer, whoever, you know, those folks are administrative as well and would be considered all other. So if I have to emphasize anything on this slide as far as RNs, that would be my sort of little tip there when I'm looking at the RNs. If I'm trying to get folks, you know, if I'm trying to optimize this and I'm looking at, okay, well, how can I reduce maybe that 82%, like in the example that Fred put forth, if I can reduce that 82%, who am I taking out of there? What RNs am I taking out of there? Well, it's those administrative RNs that are not directly involved, you know? So that's when you got to sort of talk to, you know, your nursing admin departments and find out what are these people doing.
Hey, Ryan.
Yep, go ahead, Fred.
Hey, I thank you. And I think another interesting thing that's on these slides that we've encountered every so often is CMS provides the Bureau of Labor Statistics standard occupational category, that SOC code. Some HR departments categorize their employees using that code, and it can make this exercise very helpful.
Yeah, and good point, Fred, because I mean, you probably have seen these little BLS little codes here, and these are in the instructions. Frankly, I've never really used them, but I know they exist, obviously, and it does help to sort of categorize, because if you do have that level of information. So it's a good point, Fred. Okay, so next level down here, what we're going to describe as Group 2, LPN nurses, licensed practical nurses, excuse me, or licensed vocational nurses. License required, again, similar to RNs, pretty straightforward. Generally, they work under the supervision of a registered nurse, or they're, you know, operating in a clinic or something at the capacity of an RN. Again, generally easy to identify. Where we see a little bit of opportunity here is these surgical techs. surgical technologists, which I'll speak to here in a second. But LPN is pretty straightforward. Again, these next three categories, you'll see this little thing over here, this little icon, occupational mix adjustment. That little arrow is meant to say that's going to improve your adjustment factor. So these lower level nursing categories are really where you want to sort of roll up the sleeves and start scrubbing. I would say LPNs and surgical techs are probably the least scrubbed, if you will. The nursing aides and orderlies and attendees is probably where you'll get the most bang for your buck, but we'll talk to that in the next slide. So let me talk about nursing or surgical technologists for a minute, and I'll just sort of give you my little tip there. Assistant operations under the supervision of surgeons, RNs, and other surgical personnel, okay, may help set up operating room, prepare and transport patients for surgery, adjust lights, pass supplies to the surgeons, count sponges, etc. Right? So some examples are OR techs, OB techs, folks that are in the labor and delivery cost centers, perioperative specialists, etc. So for this particular category, what I like to focus in on is the surgical techs, and in terms of, I'm going to look at folks in my worksheet A line 50, right? My operating room cost center. Really hone in on that cost center and say, who's working in there, right? What nursing folks are in there and what are they doing? Are they involved in surgery? Are they helping transport patients? Are they, what are they doing? A lot of the surge techs are pretty easily identified. They're identified as OR techs or OB techs or whatever it may be, but certainly keep in mind. One sort of, also I'll mention here, one thing that CMS does call out, and I've had Max call out this and look at this in particular, is they're pretty limited in terms of, or I should say the instructions are pretty explicit about solely identifying surgical techs, when we get into the word tech, right? Equipment techs, an EKG tech or a, what else, these other techs that may be monitoring equipment or something, CMS explicitly calls those out as all other. I have seen hospitals tend to want to bury basically any tech in here, but I don't think that's appropriate. And CMS does specifically call those out. So just pay attention to that if you're trying to move anybody that's identified as a tech. Really focus it on the line 50, like I said, from worksheet part A, or worksheet A, excuse me. Okay, let's talk about this one. We've got about 20 minutes or so, so I think we're timing-wise, we should be okay. And I've seen some questions come in, so I think we should have some time here at the end. Nursing assistants, right? So this is assistants, orderlies, attendees, what we're identifying as group 3. Pretty basic instructions here on this, right? You've got, this one can be difficult to identify because you've got so many different names and different organizations. So this one's real important to kind of look into, but let's just kind of read through this. Nursing assistants provide basic patient care under direction of a nursing staff. Okay, that's pretty straightforward. May feed, bathe, dress, groom, etc. May transfer or transport patients. So you've got patient transporters. Make sure you're looking at those. So here's some examples. Certified nursing assistants. Okay, those are the most obvious ones, right? Pull those out. Nursing care attendees, nurse aides, nurse attendants, patient care techs. I've seen ER techs. Pay attention to those folks that are in the ER. Again, on the front lines. Patient aide, hospital aides. There's your emergency medical technician. Infirmary attendees. I'm not sure I've seen a whole lot of that, but I'm sure they're out there. Nutrition attendant. Well, that's interesting, but certainly pay attention to what cost center those are in. Transports patients, so these are your orderlies, may stock, again, depending on where they fit, make sure they fall into those cost centers. So some of these may be your unit secretaries. Pay attention to those unit secretaries, orderlies, patient transporters, sitters, patient sitters. So our little tip here, just to point out, similar to unit secretaries, your ward clerks, right? Your ward clerks, your unit secretaries, those that are kind of on the floor, just sort of helping oversee things in terms of patient care. Pay attention to the job descriptions there. Pull your job descriptions, review them in depth, and determine if they're filling roles that belong in this category. If they're not doing it under the direction of a nursing staff or RN or whatnot, they should be all other, right? One thing I'll mention too, that maybe I didn't already mention, is CMS does sort of acknowledge that You may have folks that are kind of doing multiple roles. They're kind of in different, particularly at smaller hospitals. You could get creative and try to talk about, well, maybe he or she does 50% here and 50% here and reclass some of the salaries. That gets a little complicated. What CMS basically says is, hey, wherever they spend the majority of their time is what you should categorize them accordingly. So keep that in mind. And lastly, and I won't spend too much time on this one because frankly, medical assistance is probably the least categorized, if that makes sense, of the 4 nursing categories. And I'm going to say, I don't know this off the top of my head, but it's generally 3% of nursing or something. It's a relatively small number, maybe 5%. If you're seeing anything more than that, you probably want to question it in terms of the hours relative to the total nursing. Examples of medical assistance performs, what the definitions are: performs administrative and certain clinical duties under the direction of a physician. May schedule appointments, etc. So you tend to kind of see these in like the clinical setting, in your outpatient clinics or your hospital-based clinics. Examples are medical assistants, physician aide, morgue attendants, etc. Make sure you don't include, and these are in the instructions to exclude, physician assistants, phlebotomists, informational technologies. You tend to see some of these in the clinic setting. So our little tip here: include only those employees who perform administrative and certain clinical functions, is the key, under the direction of a physician, while working in a department that falls. So that's sort of a twofold thing. They're working, they're performing administrative and certain clinical duties under the direction of a physician, but still fall within a department that falls in those core nursing categories. So a hospital-based department of some sort. And again, if you're seeing a lot of these, you might want to question it. So hopefully that makes sense in terms of the nursing categories, and hopefully that provided some sort of insight. Before we talk about the next category, the catch-all, all other, just to give you some insight, what I do, unless you're working with a really big sort of health system where you're taking basically a bunch of hospitals and putting it in a big payroll file where maybe you need to use some sort of other non-Excel database or Power BI or something like that. You can generally do this in Excel, and you just sort of slice and dice the data. Frankly, we use kind of an old proprietary Excel workbook that I think Fred created probably back in the 80s or something, right, Fred? No, maybe not quite so long. But we still use it. It still works, and we sort of just slice and dice in Excel, sorting and going through basically, category by category and working through it and talking to HR and nursing admin departments and getting job descriptions and making the best determination from there. So it should be a pretty straightforward exercise. But again, it can take time because you really want to make sure that you are, reviewing those personnel and making sure to talk to your HR and nursing admin folks. So let's sort of briefly, we've got about 15 minutes left and I've got some questions here. So I want to make sure, I know Fred, you're sort of handling some of these as we go. Let's make sure we kind of get to these if we can. And if not, we'll catch you on the back end. All other categories, right? This is everybody else. So these are your non-nursing salary personnel included in the allowable IPPS cost centers, right? So back to that core list. If it's not on one of those core nursing categories that CMS identified, it's all other. So examples, A&G, executive suite, dietary housekeeping, so those are contract labors that we need to pay attention to. Home office, make sure you're identifying the home office allocations. If you're not a 1231, that's a little bit trickier because you got to piece together a couple segments of your year. Part A administrative positions, right? The Part B are removed, but Part A gets included. Nursing personnel who operate solely in administrative roles. That don't provide. That sort of speaks to the RN slide that I talked about. And then again, all the other nursing personnel that don't map to the core. That's sort of the first and foremost. So who are we excluding here? I think it's important to pay attention to. Okay, we remove those Part B folks, and then the advanced practice nurses and so forth. Teaching positions, basically, like I said, anybody that you identify on your S3 Part 2 that get removed separately. For the purposes of that, those get removed from the calculation. However, any personnel reported in the IPPS excluded areas So, you know, your psych units, your rehab, SNF, et cetera, those would be identified as excluded. And we'll use those in the excluded ratio calculation. So a portion of those folks need to be applied to your general services, just like we would for wage index purposes in terms of allocating or assigning a portion of those folks to be, because they're overseeing, you know, some of the overhead. So some of that gets pulled out of all other, which we can get. We're not going to get into that excluded ratio calculation, but if you have questions on that, certainly feel free to reach out to Fred or I. All right, so I know I went through that kind of fast, and I know we've got some questions, so let me just sort of get us to the finish line here, and we can sort of speak to any of these direct questions. So keep them coming. This is the form. This hasn't changed in the last few years. You know, it's kind of an ugly looking form, but it is here, and this is where this is what you actually need to be submitting to your max in terms of what goes in here, and you've got, you know, between the nursing categories and all other, there's what, 10 numbers you fill in, and that's it. And so if you've got multiple providers, you can list them all in one form and send it in, or you can do it separately. I don't think there's any necessarily requirement that you do so. But this is the form, and I just wanted to sort of illustrate it here so you can see it. And this will be, the actual Excel form will be included in your other class materials that we'll distribute after the class. So let's kind of take a peek real fast at some real life examples, so to speak. And this isn't, I'm not going to say real life examples, but I just kind of want to give you an idea of some sample scenarios you may encounter. So looking at this first one, we've got an RN as the job description in adults and peds, worksheet A line 30, pretty simple, right? Core nursing. So we've got that same RN, or maybe not the same, but another RN, same job description in the anesthesia department, line 53. Okay, well, that's all other, right? Because it's not, 53 is not a core nursing category, or excuse me, not a core nursing cost center. Another RN, rehab, worksheet A line 41. That's a non-IPPS department. Okay, not part of the survey, but used to develop the excluded ratio. Okay, so you can kind of see how we're slicing and dicing. We'll go down the line a little bit. Okay, we've got a senior accountant, finance, worksheet A, line 5, all other, easy enough, right? And that, you wouldn't even really look at that, right? You just look at the worksheet A, line 5 and go, okay, well, that's all other, that's easy enough. Patient transporter, I would consider that a nurse aide. It's in a core cost center, right? A coder, here's an interesting one. A coder in the operating room, which is kind of odd. I don't know why that would be there, but sure. You know, okay, what's this coder doing? Why is he or she in the operating room? Ask if this individual is under direction of a physician, you know, so, you know, if they're a decentralized coder, then they're probably going to be in the all other, but if they're, you know, coding specific services in the surgical, you know, department, then, you know, maybe it's going to be a medical assistant. So, you know, something you want to kind of hone in on as you're kind of looking at these things. And then lastly, contract legal, right? Make sure you're gathering your legal. That's going to be worksheet A line 5. And that's going to go in all others. And this will help kind of to the point that Fred had made in terms of the calculation. This will help kind of boost that all other percentage in terms of the percentage compared to nursing. Now that does change a little bit depending on where you fall from an occupational mix adjustment number, whether you're above 1 or below 1, but certainly you want to report that information. And we wouldn't suggest that you don't report it if you are above 1 in terms of your factor, but just something to sort of think about. So again, how can we impact it? We've kind of spoke to it already, but as we've sort of said, you know, this is an ongoing process, right? We're going to kind of close out the presentation and just sort of speak to, kind of summarize what we've talked about. If you couldn't tell from what we just talked about in terms of the detailed review, you need to be reviewing job descriptions. I can't emphasize that enough. Review your job descriptions, especially if it hasn't been done in a while, and based on the survey results, that is the case for a lot of you. And it's an ongoing process, so don't be concerned that the period has already passed. You know, it doesn't matter. You should still be meeting and identifying and categorizing from there. We encourage you, obviously, to review all your categories, especially the RNs, you know, that are maybe being inappropriately reported in a core nursing cost centers, but really belong to an excluded. Now, I don't know how often you'd see that because, I mean, they're going to be identified in the departments in which they work, but certainly something to keep in mind. You know, I'm kind of going up here a minute, but if your nursing is below 1, we've talked about that, below or above 1, certainly below 1, you want to make sure you're sort of boosting up that all other by making sure you're including your home office, including your A&G, contract labor, dietary, housekeeping, etc. Normally, housekeeping and dietary wouldn't necessarily have a positive impact on your wage index average hourly wage, but it certainly could help you here. And I won't go into this too much because we've already talked about reviewing your job descriptions, focus on new job descriptions, focus on certain ones, you know, like the coder in that example we spoke to. Fred had mentioned these SOCs. You can compare those to the CMS job descriptions if they're available, you know, but usually not. Update payroll system or job code legends for better clarity. Make sure you've got the descriptive job codes, right? Make sure you've got the detailed descriptions as opposed to maybe in California we have OSHPD categories or natural classes. That's not good enough. You want the actual job codes and what the actual description of these folks. And so I wanted to make sure I took a couple minutes here on this slide, and this may not look like much, but these are sort of, and Fred had spoke to it earlier, these are what I'm going to call other cursory considerations to think about in terms of when you're looking at your occupational mix and getting ready to get started on it, particularly if you're part of a health system, like what hospitals do I focus on? Let's kind of go through these because depending on how you kind of fall in all this, what I just said in terms of how much time and emphasis you put on the job description categories may sort of be null and void, and I use that term loosely, but may be limited, so to speak, depending on how some of this works out, right? So how material is my hospital, particularly if you're part of a health system, how material is my hospital's average hourly wage to its CBSA? Well, if I'm a small, you know, urban hospital in Los Angeles or something, maybe it's not that material. So maybe, you know, I'm not saying don't spend any time on it, but you know, you probably got bigger fish to fry, so to speak. You know, focus your priorities somewhere else potentially, but make sure you do it compliantly and get it done. Are you reclassified? You know, do you reclassify to another CBSA, and how does that impact sort of your percentage in the respective CBSA that you're reclassifying to? What is your occupational mix adjustment for other hospitals that reclassify? Really what we're sort of saying there is, you know, pay attention to kind of, you know, who's in your particular population if you can, and we're happy to provide some of this detail, but if you can, you know, where do I sort of rank in terms of that, in terms of my percentage and what's their occupational mix adjustment? How do I compare? Do you receive the rural floor? If you receive the rural floor, then frankly, it probably doesn't matter, but then keep in mind, this is a 3-year exercise, so it's going to be applied for 3 years, so things could change in that 3-year period. So pay attention to that. Frontier states, for those of you that don't know, Montana and North Dakota, South Dakota, Wyoming, I think Nevada, you know, they're going to get a rural floor, they're going to get a wage index of 1. So theoretically, the occupational mix doesn't necessarily apply, but, you know, CMS could do something with that frontier state provision if they wanted to. And then lastly, what were the results from your CBSA or even your own hospital's data from the last survey? Always compare to the prior year. You know, shouldn't necessarily, you know, I always sort of say this to staff I work with and whatnot too, you know, pay attention to the prior year, but certainly be professionally skeptical about it, right? You know, if it doesn't make sense in the prior year, don't necessarily hold it to the truth, but just pay attention to that, because that's certainly what the MAC's going to do, right? Their reviews are going to be sort of high level. They're going to compare to prior year, and they're going to question any anomalies. So be prepared to respond to that. All right, I think we're getting close here to the finish line. Resources, these will be in your other class material. We just leave you with this listing to access survey forms, instructions, the calculator that we spoke to, and some BLS information. All right, questions. We'll come to those in a second. That's all the material we have on the topic of occupational mix. Let's go ahead and revisit the Q&A, and Fred, maybe you can speak to anything that's still open, as I know you've been addressing those. You know, thank you all for participating. Thank you all for your questions. Fred, I'll turn it back to you for a second here to see how we are on the questions before we sort of close this out. We've got a few minutes left.
Can you hear me? I was doubly muted. You can hear me, right? Thank you, Ryan, and thank you, everybody. Yeah, we do have some questions here. Most have been I've been answering as Ryan's been talking. Someone recently asked, how would you find out what the results of the 2017 survey for your CBSA? CMS does have them, the results kind of built into, messy public use files, meaning the data's there, you have to compile it and present it with meaningful information. We have all that, so anybody that is interested in, we have these dashboard reports that are good for even executives. If anyone's interested in our breakdown, we'd be more than happy to send that to you for your CBSA. We also have a question on if the slides will be sent. So after this webinar, there'll be an email going out with a link to Toyon University's website, and the slides will be linked right up to the website there. So yes, the slides will be sent to everyone. That is pretty much it. I mean, we do have questions that were answered in respect to 2 minutes. I don't know if we have to go through any of those, but we are here as a resource. I mean, one of the reasons we wanted to do this again is because this is a 3-year exercise. Ryan and I and a number of people of Toyon, for better or worse, we've retained it in our brains and are more than happy to, to help as you guys encounter questions, encounter issues. Please feel free to reach out to us anytime. It's what we do. We react, to the industry and provide you guys what you need. So please feel free to reach out anytime. And with that, Ryan, you want to say goodbye to everybody? And this is a goodbye from Fred. And again, thank you very much for your time this morning. It's always nice to talk with the industry.
Yeah, no, thank you everyone for your participation. Certainly, we want you all to, we know you got a lot of priorities, so we appreciate you spending about an hour and a half with us this morning. Stay safe and healthy out there. And of course, we look forward to speaking with you soon. I noticed a couple of chats on here. I think we got to those. Let me just make sure. Okay, thanks, Fred. Yeah. All right. Well, again, thank you all. Again, stay safe, healthy. Hopefully that's first and foremost in everybody's priority here. And we look forward to speaking with you soon. I'll let May close us out here.
Thank you, Fred and Ryan. That concludes our webinar. Once again, we will put class material as well as a copy of the slide deck on our Toyon University website for your reference. We would appreciate your feedback on the survey for this webinar, and thank you for attending today's session of Toyon University. Have a great day and stay safe, everyone.
Thank you all.